Assalamu alaikum and welcome to the Medical Concept with Dr. Falak. Every day, thousands of patients around the world survive because of a simple yet life-saving procedure, that's the blood transfusion. Have you ever wondered how blood from one person can safely enter the body of another, and how do doctors ensure compatibility, and what complications can occur and how are they prevented? So, whether you are a medical student, healthcare professional, or simply curious about the topic, this video is for you. So let's begin. In this video, we are going to explore the indications and precautions of blood transfusion. We are going to also discuss about the acute and delayed immune and non-immune blood transfusion reactions, and we are also going to explain the various pathophysiological mechanisms of jaundice, hemolysis, and acute kidney injury in this video. Now, what is blood transfusion? Blood transfusion is the process of transferring blood or its component from one person, the donor, into the bloodstream of another person, the recipient. This blood transfusion can be in the form of whole blood, fresh frozen plasmas, PET cells, also known as red blood cells, and cryoprecipitates, that are also known as clotting factors. This blood transfusion is a life-saving procedure. Now, coming to the indications of the blood transfusion. Blood transfusion is required in case of severe anemia, hemorrhage, trauma, extensive burns, and complicated surgical and obstetrical procedures. Here you can see in case of severe anemia, blood transfusion helps to increase the red blood cell count and improves oxygen delivery to the tissue. In case of severe hemorrhage, it replaces blood loss and helps maintain circulation and organ function. In trauma, it restores blood volume, prevents shock, and supports survival. While in case of extensive burns, blood transfusion replaces fluid and the blood loss, maintains blood pressure, and support healing and recovery of the patient. While there are surgical and obstetrical indications that require blood transfusion, and they include major orthopedic surgeries, cardiac surgeries, neurosurgeries, thoracic surgeries, major abdominal surgeries, trauma surgeries, organ transplantation, and obstetrical emergencies like antepartum hemorrhage and postpartum hemorrhage. In all these cases, timely blood transfusion can save lives and improve the outcome of the patient as well as the baby. Now, before transfusion, there are certain precautions that should be taken. Before transfusion, make sure the donor should be healthy. He or she should not be having any acute or chronic viral, bacterial, or other type of disease or infection. Matching and cross-matching should be done. And make sure that RH compatibility must be confirmed before transfusion. While during transfusion, first of all, check patient identity, his blood group, and RH factor. Then check expiry date and the bag integrity. Make sure that all the technique and the apparatus is sterile. Blood bag should not be too cold, and make sure that the transfusion is started very slowly until unless indicated. During transfusion, monitor vital signs that include pulse, blood pressure, temperature, as well as respiratory rate. And stop transfusion if you are suspecting any type of reaction. Now there are two different concepts, blood matching and cross matching. They are also very important. Now coming to the blood matching. Blood matching is the determination and comparison of the blood group, that is both ABO and RH factor of the donor and recipient before transfusion. It means that the donor and recipient should be having same blood group. Okay? The blood group and the RH factor should be same. So if the donor and recipient ABO and RH group are same or compatible, then proceed to cross match. Otherwise, just suppose that donor's blood group is B positive, but the recipient blood group is A positive. It means that they are not blood matched and they should not be receiving any type of blood transfusion. Another concept is the cross matching. This cross matching is usually performed before transfusion. In that case, you can see here donor red blood cells. They are mixed with recipient serum to check for agglutination or the reaction of hemolysis. If there is no agglutination, no hemolysis, it means blood is compatible and can be transfused safely. But if you are going to find agglutination or hemolysis, it means blood is not compatible and it cannot be transfused. Okay, so sometime for blood matching you will also find a term group and hold. So group and hold means that just do the blood matching and hold until unless cross matching is done. Now, this slide shows the transfusion reaction. By definition, any adverse event associated with the transfusion of whole blood or one of its component is known as transfusion reaction. These reactions can be mild to severe and they can present during the transfusion or within 24 hours. In that case, they are referred to as acute transfusion reactions, or they can represent themselves within days to weeks later, and in that case, they are known as delayed transfusion reactions. These transfusion reactions can be both immunological or non-immunological type depending upon the mechanism behind. So here you will find list. You can read the list here of both immunological and non-immunological transfusion reactions. Now let's discuss them one by one. Now let's discuss acute blood transfusion reaction. These are adverse reactions that occur during transfusion or within the first 24 hours after receiving the blood. For simplicity, we can divide them into two major categories: immune reactions and non-immune reactions. Now first discuss immune reactions. The most serious immune reaction is the acute hemolytic reaction. This usually occurs due to ABO or RH incompatibility. The recipient antibodies attacks the donor red blood cells, causing their destruction or hemolysis. Patient may develop fever, chills, flank pains, hypotension, hemoglobinuria, disseminated intravascular coagulation, and even acute renal failure. Another common reaction is the febrile non-hemolytic transfusion reaction, or FNHTR. This occurs when the recipient antibodies react against donor white blood cells or cytokines present in the stored blood. Patient typically present with fever, chills, and rigors. Allergic reactions occur due to hypersensitivity to plasma protein in the donor's blood. Clinical manifestation ranges from mild itching and urticaria to severe anaphylaxis. Then bacterial contamination of the blood product can result in septic transfusion reactions. Patient can develop high fever, hypotension, tachycardia, and may progress to septic shock. Now coming to the non-immune reaction. One important complication is the transfusion-associated circulatory overload, also known as TACO. Here, excessive transfusion can cause volume overload, leading to pulmonary edema. Patient present with dyspnea, tachypnea, hypertension, and raised jugular venous pressure and pulmonary congestion. Electrolyte disturbance may also occur, especially during massive transfusion. Hyperkalemia and hypocalcemia are the most common abnormalities. Finally, faulty transfusion technique can lead to air embolism or thrombophlebitis. Patient may complain of sudden shortness of breath, chest pain, anxiety, or hypotension. Now, one important key point for exam: immune reactions involve a immune response against donor blood component, whereas the non-immune reaction results from volume overload, electrolyte disturbance, infections, or technical errors. Now let's discuss delayed blood transfusion reaction and complications. Unlike acute reactions, these occurs days, weeks, or even months after a blood transfusion. Although less traumatic than acute reactions, delayed complication can have significant long-term consequences and therefore they require careful monitoring. First is the delayed hemolytic reaction. The first complication in which previously formed antibodies gradually attack transfused red blood cells. The damaged cells are removed by the phagocytic white blood cells, leading to their destruction. This reaction usually develops several days to weeks after transfusion and commonly present with anemia, mild jaundice, and low-grade fever. Next is the iron overload. Iron overload is also known as hemosiderosis. This occurs in patients receiving repeated or massive blood transfusion, such as those with thalassemia major or chronic transfusion-dependent anemias. Excessive iron accumulates in vital organs, including liver, heart, and endocrine glands, potentially causing organ dysfunction and failure if left untreated. Third, is the transfusion transmitted infection. Despite rigorous screening, blood transfusion can rarely transmit infectious disease. Examples include hepatitis B, hepatitis C, HIV, malaria, and syphilis. Modern donor screening and laboratory testing have dramatically reduced these risks, making blood transfusion much safer than in the past. Fourth is the graft versus host disease. It's another rare but serious complication in which donor lymphocytes survive in the recipient and begin attacking the recipient's tissue. This complication is seen mainly in immunocompromised patients and can be life-threatening. Fifth is the alloimmunization. Following transfusion, the recipient may develop antibodies against donor red blood cells antigen. These antibodies can complicate future transfusion by making it more difficult to find compatible blood and may increase the risk of hemolytic reaction. So in women, alloimmunization can also create complication during future pregnancies. So take home message is that the major delayed complication of blood transfusion include delayed hemolytic reaction, iron overload, transfusion transmitted infections, graft versus host disease, and alloimmunization. So careful donor screening, proper blood matching, and long-term patient monitoring are essential to minimize these complications and ensure transfusion safety. Now let's understand what happened during a mismatched blood transfusion, one of the most dangerous transfusion reactions. In this example, a patient with blood group O mistakenly receives blood group A red blood cells. Remember, the individual with blood group O naturally possesses antibodies of both anti-A and anti-B in their plasma. So first step is the antibody binding. As soon as the donor red blood cells enter the circulation, the recipient's anti-A antibodies they recognize and bind to A antigen present on the donor red blood cells. Thus, immune system identify these donor cells as foreign and immediately produce a response. The second step is the agglutination. The antibodies act like bridges. They link multiple donor red blood cells together. This causes clumping or agglutination of the transfused red blood cells. These clumps can obstruct small blood vessels and impair normal blood flow. The third step is hemolysis. The agglutinated red blood cells are rapidly destroyed. They release large amount of hemoglobin into the plasma. This process is known as intravascular hemolysis and it is a hallmark of acute hemolytic transfusion reactions. Another interesting thing is that why donor red blood cells they are affected more than the recipient red blood cells. So this is because the recipients already have a large quantity of circulating antibodies while the transfused donor blood represent only a small fraction of the total blood volume. Therefore, the recipient's antibody overwhelmingly attacks the donor red blood cells rather than recipient's own cell. So the clinical consequence can be so severe. Patient may develop fever, chills, back or flank pain, hypotension, hemoglobinuria, which appears a dark colored urine. If the reaction progresses, acute kidney failure, circulatory shock, disseminated intravascular coagulation, and even death may occur because of mismatched blood transfusion. Let's see how a mismatched blood transfusion can lead to acute kidney injury. When a donor red blood cells are destroyed or hemolyzed, large amount of hemoglobin are released into the bloodstream. Normally, a protein called haptoglobin binds free hemoglobin and helps remove it from circulation. However, during massive hemolysis, haptoglobin becomes depleted. The excess free hemoglobin is then filtered by the kidneys and enters the renal tubules. In the renal tubules, it causes direct tubular toxicity, oxidative damage, and forms hemoglobin cast that can obstruct the tubules. At the same time, free hemoglobin reduces nitric oxide availability, causing renal vasoconstriction and decreased blood flow to the kidneys. Together, tubular injury, obstruction, renal ischemia, they all result in acute kidney injury. The key point is simple. Hemolysis will lead to free hemoglobin release, which will then cause haptoglobin depletion. Ultimately, kidney damage will lead to acute kidney injury. Let's understand why jaundice develops during a transfusion reaction. In an incompatible blood transfusion, such as ABO mismatch, donor red blood cells are rapidly destroyed by the recipient antibody. This hemolysis releases large amount of hemoglobin into the bloodstream. Hemoglobin is then broken down into heme and eventually converted into unconjugated bilirubin. When red blood cells destruction is extensive, unconjugated bilirubin is produced faster than the liver can process it. As a result, bilirubin accumulate into the blood and get deposited into tissues, particularly the sclera of the eyes and the skin. This produces the characteristic yellow discoloration that is known as jaundice. Over time, some bilirubin is excreted through bile into the intestine and appears as stercobilin in stool, while a small amount is excreted in urine as urobilin. Another important concept is of exchange or replacement transfusion. It's a process which involves removal of patient's blood completely and replacement with fresh blood or the plasma of the donor. It's a life-saving procedure which is required in case of severe jaundice, sickle cell anemia, and erythroblastosis fetalis, and etc. The purpose is that it removes harmful substances like bilirubin or abnormal hemoglobin. It replaces healthy donor blood and it improves oxygen carrying capacity and reduces complication. Now let's discuss one of the important MCQ with relation to blood transfusion. A 28-year-old woman with postpartum hemorrhage received 2 units of packed red blood cells. 15 minutes into the second unit, she developed fever, chills, hypotension, flank pain, and dark urine. The transfusion is stopped immediately. Laboratory tests showed elevated lactate dehydrogenase and indirect bilirubin. What is the most likely diagnosis? So, what's your answer? So the correct answer is acute hemolytic transfusion reaction. Let's discuss another. A 65-year-old man with myelodysplastic syndrome receives repeated transfusion over several years. He now presents with fatigue, bronze skin pigmentation, diabetes mellitus, and cardiomyopathy. Which complication of transfusion is most likely the cause? In this case, they are talking about the chronic or delayed complications of blood transfusion. So here the answer would be hemosiderosis. Okay. So thank you for watching. I hope this video helped you understand blood transfusion more clearly. If you found it useful, please like, share and subscribe to Medical Concept with Dr. Falak. See you soon in the next video. Allah Hafiz and take care.